All right, we're going to talk about, again, the initial assessment of gunshot wounds to the face. Again, pre-hospital report is an interesting thing. It's helpful. It's good to have some time ahead of time, especially for a patient who's a gunshot wound to the face. It's not always all of the story. It's not always accurate, but it's still nice to have. So when you have the report of gunshot wound to the face, you really want to prepare your team. Take that couple minutes you have and really focus on airway issues. What are they going to be? Big concern for these patients. They may also have issues with bleeding. Certainly they may have other wounds. Again, in Philadelphia, the average patient who comes to a Philadelphia Level 1 trauma center, I think has 3.4 gunshot wound holes per patient. So these patients may have been shot in other places. And then again, just come back to airway issues. And I purposely added another picture of a Yankauer suction, because one of the things we do, if we have somebody who's coming in with a gunshot wound to the face, we make sure we have 2 functioning suction catheters up at the head of the bed to help us clear the airway if we need some issues. Now, we tend to be creatures of habit, so everybody's got to be evaluated laying flat. It's the only way we know how to do things. If they're not flat, it totally messes us up. Somebody comes in shot in the buttocks, laying on their stomach. The trauma team is paralyzed. We have no idea what to do. I'm like, let's examine, do a rectal exam. What the hell? Ass, breathing, circulation, it works good. Don't try not to, get totally discombobulated with this. A lot of times these patients are brought in because they get a little bit combative when you lay them flat because they start aspirating blood. And a lot of times they'll come in and maybe they'll even be spitting into a bucket. So we take these patients sometimes and allow them to stay in the position of comfort. If they can help you manage their airway while you're sorting things out in the first few minutes of the trauma resuscitation, it's fine. We get them a little emesis bases, have them sort of spit into it. If they're awake enough, we can give them a Yankauer suction. They can put it in their mouth and help suck some of this stuff out. We hesitate to lay them flat because we know they're going to aspirate. If these patients come in with a cervical collar, we're okay with that. If they don't come in with a cervical collar, we're okay with that too. If these people are shot in the neck, a cervical collar often covers up the wounds. You don't see a hematoma that is small but getting bigger during your prompt evaluation, and they can sort of set you back a little bit. It's very, very, very rare for somebody to come into our trauma bay with a gunshot wound to the neck who is neurologically intact and has an unstable cervical spine injury. We see many patients who come in with gunshot wounds to the neck who are paralyzed because the bullet's gone through their spinal cord. In fact, at the Hospital of University of Pennsylvania, even though we're a regional referral center, the number one reason we have para or tetraplegics is from gunshot wound violence. It's very unfortunate. So we tend to not necessarily be overly excited about rushing to put a collar on one of these patients. It doesn't mean that we're not eventually going to image their C-spine, and if we ever find the patient who has an unstable fracture, we're going to very humbly put a collar on and be happy with it. But we don't rush to do it because we want to look at wounds, and if somebody's developing an airway issue while we're evaluating them, we want to know that. Now again, you evaluate these patients in the same way, even though sometimes their presentations are quite dramatic. Their airway, breathing, circulation, disability, and exposure are done in a rapid fashion. Now remember, ATLS teaches in general that if you have a letter of the alphabet that's broken, you want to fix it right away. Well, in these kind of patients, absolutely you want to try to make sure as you get your airway stuff together, do a quick disability exam. Because once you paralyze that patient, if that's the way you intubate them, you're going to lose that exam for a while, and you want to know if they're not moving their legs, if they're not moving their arms, if they have something wrong with them. It can give you another trajectory point, and it's also a good thing to know as you sort out the rest of their issues. Now, the airways can be quite challenging. Can be a lot of edema. If the wound has occurred a while ago, there can be bleeding, distortion of normal anatomy. This is really a time for your airway guys to step up and use all of the resources that they have available to try to successfully manage an airway. And as trauma surgeons, we have to be prepared to step in with a surgical airway. You have to make a decision about how you're going to intubate these people. Is there a role for awake intubation in some of these people as opposed to giving them RSI meds where they'll be paralyzed and you'll be easier to maybe put a laryngoscope in and take a look at the airway and hopefully intubate them, but they'll stop breathing with that paralytic issue that you give. When do you lay these guys flat? If you're going to try to look with a laryngoscope, while it's nice to have them sit up, it's awkward to try to intubate them while they're sitting up unless you're doing an awake intubation. You want to have a lot of suction around. We tend to, as they fasciculate, that's when we lay them down, suck out their airway as much as we can with 1 or 2 suction catheters, and then try to place the tube. And securing the tube is not a chip shot either. This patient who I showed here, you can imagine if this patient had been successfully intubated, Suddenly trying to secure that tube so it doesn't move as you go through the rest of the evaluation might be quite a challenge. We always have these patients, we prepare for failure. I love to get some lidocaine with epi, figure out where I would make an incision for a cricothyroid otomy and sort of numb that skin up. If we successfully get the airway from above, the patient has a little bit of numb skin for a little bit. It's not that big of an issue. But if we have to make an incision and it just minimizes bleeding even a little bit, that can be helpful. So we tend to prepare for that. We have a trach tray, we open it. If we don't use it, great, we'll re-sterilize it. Not that big a deal. Have our tracheostomy appliance available. I can tell you if we have everything available and are preparing for failure, it rarely happens. The one time we shortcut a step, that's almost a guarantee that we'll end up needing these things. Cricothyroidotomy, I'm not going to spend a lot of time, and I like to make an up and down incision as opposed to a horizontal incision. If it's really a one-person incision, I'm a right-hand dominant person, I can take my left hand and push down on the neck, pull my skin incision open, and not have to operate on top of my thumb to do the rest of the procedure. If I make a transverse incision and try to do the same thing, my big fat thumb is in the way. Cosmetically, it might not be as appealing, but at that point, I'm not really that worried about cosmesis. Transverse incision to cricothyroid membrane spread and place your tube. And always remember to check for end-tidal CO2. It is possible in a crisis situation to place your airway device in the anterior mediastinum right in front of the tracheostomy and not actually into the trach. It's great to use a tracheostomy appliance. If you use an endotracheal tube, that's okay. Just remember you have to secure it afterwards and that it's going directly into the neck, into the airway. It's not going through the mouth anymore, so the amount of the tube that's sticking out of the patient is going to be more than you're usually used to. Many times we, in the heat of battle, have placed that tube in further because it now looks more like it does when it comes out the mouth, and shoot an x-ray and find out we have a right main stem intubation. The procedure to me is always harder than it looks. It looks easier than it really is. Difficult airways usually are people who have difficult necks, and I've had many patients who had big hematomas. We couldn't intubate them. When I make an incision in the neck, their hematoma decompresses, and it becomes very difficult also. And the patients who are not shot in the face is the ones we're talking about today, but for whatever reason our airway team can't intubate them properly. It's often because they have a short, squat neck, and doing a cricothyroidotomy is not a picnic either. I'm not going to talk a lot today about whether you have to convert these to formal tracheostomies near immediately or if at all. Can you just decannulate them directly, and how long-term follow-up is probably needed for these. To finish the issues about airway, all these patients have aspirated. Just plan on it. When they were shot, when they were getting ready to be intubated, all those things, they've aspirated and swallowed blood, so you need to appropriately suction the airway and decompress the stomach. This is a patient who had an isolated gunshot wound to the face. This is his chest x-ray after he's intubated and a subsequent CAT scan that shows the significant aspiration event that he had during this event. From a circulation standpoint, bleeding can certainly be an issue. Maybe there's some injuries to the tongue. You can sort of try to whip stitch. But deeper wounds can be quite challenging. Sometimes if we have other pressing needs in these patients, we'll actually use a Curl-X or two and literally pack the mouth to try to tamponade bleeding. If you do this, you want to make sure to decompress the stomach as you get ready to do this. If you try to decompress the stomach after you've packed the mouth, you sort of realize you forgot something. You got to keep these people very asleep and sedated. It is very awkward for a patient to wake up with an endotracheal tube and their mouth packed. It's really not anything you want them to experience. And then you have to move on with the evaluation of these patients. We've also used on occasion Foley Tamponade in wounds to the face. This is one in the neck, but someone who is, we put them through the gunshot wounds, blown up the balloon, and temporize some bleeding with these. You have to remember to clamp the end of the balloon. The object is not to have the blood drain out as if it was urine at the end of your Foley. But it is a way to sort of do it. And then you got to move on with your evaluation of the patient. So we start our evaluation of these patients. We obviously do a chest x-ray on them, but we love to do what's called a big head film. We take a big chest x-ray size plate, put it behind their head, neck, and upper mediastinum. And again, we try to, as best we can, use paper clips for wounds, although some of them are hard to whatever. This is a couple slides here to remind me to tell you to do things that better than I do. This patient, we forgot to take out their tongue stud and some other decorative hardware they had. It makes it hard to interpret the films. And also, we like to have the head turned straight, not turned sideways like we did here, but this patient had a paper clip on his left over his mandible and foreign bodies in his posterior. And this is how film really should be better done, that big head film. It gives us some information if there really are foreign bodies. You have to be careful. Sometimes people have some some dental hardware, some fillings and things like that, that on a quick glance you can mistake for foreign bodies when you look at those big head films. Certainly, I think the hallmark evaluation this day and age is cross-sectional imaging. These patients usually get a CT of the head. It's hard to figure out from a trajectory standpoint if any of these have actually injured the brain. CT of the max face will be helpful. Your facial surgeons who might ultimately have to reconstruct them are going to want that study. You want to look at that C-spine in the neck, and we usually do a CTA all at the same time. And again, in this day and age with CAT scanners, this can usually be done pretty quickly. This is a Maxwell Facial Ct that shows of that patient who had his head turned sideways. That shows the bullet, and you can see the trajectory with some mid-face injuries that this patient had. Now, this patient, look at this guy, was shot from a distance and was shot, and so either it was dumb, how they did not hit his torso, I'm not sure. But he got shot below his left eye. He has a little bit of an injury that you might be able to appreciate here, and his bullet was back in his brain. So you need to do a CAT scan of the head and make sure that some of these trajectories do not include intracranial trajectories. And a lot of them have a lot of destruction. You have to play with the windows because on some of the windows you can see a lot of scatter from the retained foreign bodies, especially if the foreign body is fragmented. But bleeding control, we've talked about a little bit now. It certainly can be somewhat challenging, and certainly depending on where the wound is, there may be a role to have your surgical consultants help out. We have 3 different services that cover facial trauma, and they're really a big help in these kind of patients. It sort of is an exciting challenge for them, and they hop to it. And that being said, more often than not, angiographic embolization is the way to go with these people. And whether you do them in an IR suite or in a patient who's shot multiple, you end up in a hybrid OR and you're able to transition from caring for their abdominal injuries to having your IR or neuro-IR team in a hybrid OR is something we're all evolving towards. And it's described, at least in very dramatic situations, to actually get ultimate proximal control and ligate the external carotid artery. I've never had to do that, but I have read about it in textbooks. So this is an example of that patient who had the CT that showed the trajectory across his midface and had his head turned sideways. He went and he had an angio that showed a nice blush off the facial artery, and then hopefully you can see these coils that our neuro-eye guys swiftly put in, and it showed that the bleeding was largely controlled, and that eventually completely thrombosed. Now, this is the same patient. A lot of these patients have other issues as well. This patient had multiple injuries. He had a gunshot wound to his abdomen, required a laparotomy. He had a gunshot wound to his leg that ended up having an SFA injury, so he ended up with a shunt there. His abdomen temporized damage controls, then the CT, having all kinds of things done. You have to coordinate your team, coordinate your resources, and it might be a role in some of these situations to do some of the temporizing maneuvers that you've heard about in other talks and certainly at other lectures at other meetings. Some other issues to figure out in these patients, your intubated facial trauma patient who you've successfully orotracheally intubated, is that airway secure? It's something you need to think about. If you're in a situation in the ICU where you are heavily sedating that patient because you're worried that if they wake up and they pull that endotracheal tube out, they're just going to die because you're not going to get the tube back in, that airway probably is not overly secure. There's a real downside to heavily sedating patients in the ICU. And a lot of these patients, if you do an early tracheostomy in these groups, you can have them awake off the ventilator on trach collar before you know it. So these are certainly patients that, depending on their injury complex, especially if there are injuries below the hard palate, we tend to be pretty aggressive at traching them in a timely fashion. So in summary, you want to control the airway in these patients. It's very important. Some of them have bleeding issues that need to be controlled either directly with some direct pressure or possibly with our endovascular techniques. You got to manage all the injuries that these patients have because usually they have other gunshot wounds that you need to take care of. And again, just keep an eye on that airway. Even that patient who comes in with a stable airway, it's very possible that in the next few minutes as you're evaluating the patient, that stable airway becomes an unstable airway. So thank you very much. Pleasure to be here again.